Well, this is Bob Browner with part two of Improving Nebraska Healthcare. We'll talk about why U.S. and Nebraska's healthcare is so expensive, and it helps to start with comparison. So how does the United States shake out compared to the rest of the developed world? The black line above is how much we spend on gross domestic product on healthcare versus all the other countries. We started diverging in 1980. We've been getting more and more expensive than them compared ever since. There's a lot of white space between us and everybody else. We spend on average about twice what other countries spend on healthcare per capita. Nebraska is even a little worse actually. It's hard to find good data, but I'll show you a couple of smattering of examples. This is from the advisory board where they actually rank the states from 1 to 50, with Nebraska coming out with the third highest healthcare costs. The Healthcare Cost Institute puts out fact sheets periodically, and the most recent one they have, they don't do rankings, but they actually do absolute dollar amounts, so around $7,700 per person, more expensive than the United States and most of the surrounding states except Wyoming, which you'd expect because a rural state, the per capita healthcare tends to be a little more. Out-of-pocket costs, though, almost $1,300 is more than everybody, including Wyoming. However, within Nebraska, there's some very different rates of costs, and so healthcare costs are somewhat local. So if you look on the right, Lincoln is less than national averages for spending, but Omaha is a bit more. And there's some structural reasons for that, and this fits with other data that I've seen. If you want more of an academic perspective, Health Affairs is the top policy journal in the United States. This was an article a few years ago where they actually looked at every state and then adjusted for things like incomes and age and health conditions and things like that. Basically, after adjustments, Nebraska was number 9 in total health care costs per person. And if you look at out-of-pocket costs, echoing the Healthcare Cost Institute, we were number 7 for out-of-pocket costs. So again, a major issue for the average Nebraskan. And I remember this was about 10 years ago. Warren Buffett at his at the Berkshire Hathaway annual meeting was quoted as saying medical costs are the tapeworm of American economic competitiveness. And it's one reason we don't have as much money left over for spending on things like education, for example, because healthcare is eating too much of it up. So we'll talk about what's wrong, and I'd put it in 2 buckets. One is a lack of prevention. 2 is the amount of waste in our system, and I'll start with the prevention, using the analogy of oil changes versus engine replacements. So if you do a good job of maintaining your engine with oil changes and preventive maintenance, you can probably get 200,000 to 300,000 miles out of your engine. However, if you try to save a little money by skimping on oil changes, it'll come back to bite you later because then you'll have an expensive engine replacement. United Healthcare is kind of the same way. We don't put enough money into primary care and prevention and effective employee wellness, and the result is we spend more money on heart attacks, strokes, and cancers. The cheapest heart attack is the one that doesn't happen. So by comparison, most developed countries with high-performing health systems spend about 10 to 15% of the total budget on primary care. United States, we spend about 4 to 6%. A couple examples I use is when you decide to intervene. If you decide to intervene up front, kind of like the oil changes, you can prevent those engine replacements. So comparatively speaking, an employee wellness program, you could probably do some screening and catch people before they start developing prediabetes and metabolic syndrome for about 30 to 50 bucks. Once they do develop prediabetes, you could probably do some health coaching, visits to a dietitian for a couple $100. If they're a newly diagnosed diabetic really early on, and you only need a generic medicine like metformin, you can probably control them for $500 to $1,000 a year. But then they start adding multiple medications and start having complications. You go from 10 to 50,000 to much more expensive. And so obviously it'd be better to intervene early when things don't cost so much. Another example would be prenatal care. So most of a good chunk of Nebraska meets the Healthy People 2030 goals for adequate prenatal care, but not every place. But specifically Medicaid, if you look at the Medicaid population, most of our counties are not meeting adequate prenatal care for the population. Well, if we spend a little more money there, we might save a lot more money someplace else. So, for example, Nebraska spends probably close to $200 million a year on neonatal intensive care unit admissions. If we did a better job of prenatal care, maybe we could avoid some of those. And this doesn't even include all the downstream costs that happen after the NICU admission, because not all those things are fixable. They can even result in special ed costs for schools. And so maybe if we spend a little bit more money up front, we'd spend a lot less money on the back end. The other big bucket is waste. So health policy experts for several decades now have estimated about 25 to 30% of our healthcare costs are waste due to a lot of inefficiencies in the system, everything from administrative complexity to pricing waste, for example. I like this article from the Journal of American Medical Association because it breaks it down into each of the individual buckets. Everybody likes to point at that one other guy over there, but there's lots of guys that are actually part of the problem here. So here's the list of all those areas where they estimate we are spending more than we should. I'll break them down in just a couple buckets, and we'll talk about the first 3: administrative complexity, pricing waste, and care failures. Administrative complexity first. This is a big bucket where basically a lot of, because our system is so complex and hard to work, it creates a lot of overhead on both the insurance company side and the clinic side. Good article from Robert Pearl about the middleman mentality and how it's killing American medicine. It goes into the fee-for-service system, which is a Rube Goldberg contraption of copays, deductibles, billing codes that are very expensive to operate on. Also, there's a lot of people in between that are actually each making a percentage on everything. Each of them individually might be contributing something, but overall, nobody's really made the big fix in the middle. And so the problems basically come down to administrative complexity. We have no standard billing requirements between insurers, no consistency of pre-authorizations between insurers or pharmacy benefit managers, and so it makes they are actually generating quite a bit of work at the administrative side on the insurance companies, for example. But the clinics are also having to deal with all this, and so most of your primary care clinics have a whole back office full of people basically processing claims, trying to figure out how to get paid, appealing denials, pre-authorizations, things like that. It can take a clinic weeks or months to years to get paid. We have health plan comparison charts like this, where you see something probably like this with different tiers and copays, deductibles, coinsurance. It's really hard for people to understand. I don't think it really results in any added consumerism or good judgment. Frankly, when I look at this, I just basically pick the one that has the lowest out-of-pocket maximum, because if I have anything serious, that's what I'm going to be paying at the end of the year if I have appendicitis or get a knee replacement or a severe injury, for example. Waste in healthcare from comparative purposes. This article talks about if you added all that up, or a quarter of excess U.S. healthcare spent on administration, more than double what we spend on heart care, more than 3 times what we spend on cancer. So there's all that administrative waste in the middle. So for example, I used Lincoln Public Schools as an example in the last Part 1. LPS, this is public information. They spend about $85 million a year on their health insurance premiums, plus employees are probably spending $10 to $20 million in out-of-pocket costs. How much of that is eaten up before they actually get health care? If you want to reduce some added reading, Health Affairs, if you're more of a policy person, or McKinsey & Company, and I've got links to this in the notes section if you want to do some further reading on either of these topics. Other big waste is pricing waste. So a couple examples for this. So one, this has also been very well studied. So this is an article. Jerry Anderson was actually my policy professor at Johns Hopkins, and in 2003, in a somewhat stodgy policy article, wrote this pretty blunt headline. It's "The Price is Stupid: Why U.S. is So Different from Other Countries." Uwe Reinhardt, one of the co-authors, was a famous Princeton health economist who died a few years ago. And when he died, they actually rewrote the article 16 years later and basically found that actually everything they'd written about in the first article was true, but actually more so. So actually the pricing had become even more of an issue over time. And then they added some other things like for some structural problems. So like I mentioned earlier, I circled under there underlined United States, we spend about 12% of our physicians are primary care doctors, where most of the rest of the world is 28%, reflecting that underspending in primary care and prevention. Another example I like to use, this is actually my own EOB that I got in the mail from 2019 for my family. When this EOB came in the mail, our explanation of benefits, I actually called it a non-explanation because it didn't really explain anything. All it said is that somebody in my family got a lot of service code 6. We actually had no idea what it is. We couldn't think of anything that would have cost us $1,200. So like a lot of you, we had to wait until we got the invoice in the mail and found out that it was actually lab charges for one of my daughters. Surprised us because at the appointment, it was an outpatient appointment here in Lincoln. We were told this is routine lab, shouldn't cost much, which was true. It shouldn't have cost much. The hint here, though, is they have hospital charges. So even though the lab was drawn at a clinic in Lincoln, they actually drove it down the road to Omaha, ran it at the hospital, and charged us hospital lab prices. I didn't like this, of course, and so I went to my primary care doctor's office, and I knew the office manager, and I said, hey, what if we'd come to here to get this lab drawn? And she ran the data on Medicare or the 2 largest commercial employers, and instead of paying $1,200 out of pocket, it would have been $113 to as much as $227, $1,000 less if we had just gotten it drawn someplace else. So that $1,000 did not create any value. It increased somebody's profit margin, and it came out of our pockets. That would have been money, I think, better spent someplace else. Disparities in prices. Also, at the time, I was interested in colonoscopies. I asked one of the colonoscopy centers in Lincoln, how much would you charge if I paid cash out of pocket? And they said $1,800. I looked at my EOB, a friend looked at his EOB, and it was as high as $8,000, which is odd because most of the endoscopies in town are done by the same GI group. They're using the same kind of scope and the same medications. The only difference is based on where you're having it, but it's the same procedure. and this is a common problem. So most of pricing in healthcare is expressed in percentages of Medicare. This is from an example. I was on a policy call, and there was me, somebody from Washington, D.C., somewhere from Texas. So the Friedman Group ran this data based on RAND prices to see how our states compared to each other. I asked if I could use this, and they said I could. Essentially, look at our prices for professional inpatient and outpatient facilities are actually quite a bit higher than most of the rest of the country. So again, explaining why Nebraska's healthcare costs are higher than everybody else. Now, to be fair, most people in healthcare have to charge more than Medicare. So almost nobody charges 100% of Medicare. It's a percentage above. The reason for this is that most places lose money on Medicare, Medicaid, and Medicare Advantage. So this is another site on Sage Transparency, which I've placed as a link as well. You can look at all the hospitals in Nebraska and see how they are as far as whether they make money in particular lines of business and what they charge. And so because they're losing money on Medicare and Medicaid, they have to charge commercial more. And you'll see that gray line is quite a bit higher. The question is, how much more do you have to charge, and at what point is too much? So, for example, when you look at that hospital, for example, system, you'll see that the prices for everything vary dramatically, from an inpatient physician at 153% of Medicare to an outpatient facility of 390%, where their commercial break-even is more than Medicare, but it's not 300%. So how much is too much? This is becoming an increasingly area of focus, and I'll talk more about this in part 4 in a few weeks. So if you look at that, go back to Healthcare Cost Institute problem, what's going on in Nebraska, our price increases almost all coming from the inflation of prices, not the quantity of services delivered. You'll see at the United States there's increasing quantity. At Nebraska, if anything, it's dropping. You'll see the site of service there in the right upper corner, where hospital prices are much more expensive than office price for the same thing. And part of this has to do with hospital market concentration. They use this Herfindahl-Hirschman index, and both Lincoln and Omaha are pretty highly concentrated markets, basically, which decreases competition on prices. 4 policy approaches I'll cover in part 4. Maryland, Oregon, and Indiana, California, all have kind of taken a different way of trying to limit this. Nebraska hasn't done this yet, so it might be something we want to look into, and I've put links if you want to look ahead on those. Other big bucket of waste is care failures or low value care. This is something I covered quite a bit in part 1. Essentially, that the accountable care organizations are actually focusing on better care delivery, and this is a headline from Medicare Shared Savings, where year after year, the accountable care organizations in the cost of country are saving more and getting higher quality of care. This is, one way to look at it is why would taking better care of people help? This is for Medicare patient age 65 and above. Where are the big buckets of care? What things cost the most for people over 65? Some of these things like diabetes, falls, hypertension, heart disease are all things that are controllable by better chronic disease management. And that is exactly what the accountable care organizations are doing, which I talked about last time. So if you look at this is how all of our accountable care organizations in Nebraska performed. Bryan Health, CHI, Nebraska Health Network, One Health. You'll see that down below they do work on fall risk prevention. They work on controlling diabetes and high blood pressure, putting people on statins for heart disease, and by doing a better job, that does save money year after year. So what about commercial part of insurance in Nebraska? Well, a group of us has been trying to increase the use of these quality measures in commercial contracts. Blue Cross Blue Shield has done quite a bit, for example. If we could focus on these, we could actually prevent a lot more and save money there. So hopefully this gives a pretty good example. Again, I've got links to everything. We'll come back in part 3. We'll talk about what I would ask for if I were in a private health plan. It's something that I'm working on in my day. One of my day roles is on the school board. Part 4, we'll talk about some of those state-level solutions, what other states are trying to do that maybe we could emulate here in Nebraska. So there's links in the notes section if you want to do extra reading to verify any of those things I've been talking about. And hopefully that helps, and we'll be back for part 3 in a few weeks.